So good evening, everyone. And it's our great pleasure to welcome you to the first EPUS web conference. And we're truly honored to have Professor Dr. Mohammed Al-Sada, the president of the society with us. Welcome, Dr. Mohammed.
Hello. Well, I am Dr. Al-Sada. I am the president of the Egyptian Pediatric Ophthalmology and Strabismus Society, a society that was founded 14 years ago, and it is actually the only society in the Middle East and Africa that deals with pediatric ophthalmology and strabismus problems. I would like to thank all the attendees that are going to participate with us, as well as I thank absolutely Professor Özkan from Turkey, who is one of the panelists today, and she is very well known and famous person in this field, an ex-president of the ESA, the European Society, and an ex-president of the ISA, the International Society of Strabismus and Ophthalmology. And I would like as well to thank our colleagues here from Cairo, Egypt, and Alexandria, Egypt, who are participating with us tonight, and hopefully it will be a successful reunion. EVA Pharma are the company that are sponsoring this meeting. I would like to thank them very much for their contribution. And I leave you now with the moderators, Dr. Ayman Al-Ghunaimi and Dr. Dina Hussam, to introduce the panelists and to start this event. Thank you very much.
Thank you, dear Dr. Mohammed. We are honored to have Professor Dr. Hala Al-Hilali, Cairo University, Professor Dr. Akmal Rizq, Research Institute, Professor Dr. Mustafa Shirbini, the Assistant Professor Dr. Amr Kamshushi, Alexandria University, and my colleague, my dear colleague, Dr. Ayman Al-Ghunaimi. So Dr. Ayman, hi.
Yeah, welcome. Thank you, Dina. I'd like to thank Dr. Mohammed Al-Sada, and I would like to thank all the panelists. Okay, for this night, we will have interesting case presentations. We have 4 cases to discuss, 3 strabismus cases and 1 case, pediatric anterior segment. And I'm sure the panelists will enrich the discussion. And I'd like to welcome all the audience. I'm assuring that you will find an interesting discussion for this night. I'm asking the audience that please share your experience with us. You have 2 ways for this. We will launch polls during the presentations. So please share our poll when it appears. And there is a button called Q&A, which means for questions and answers. If you have any question about any case for the panelists, please post it in the Q&A, and we will collect it and ask it to the panelists for discussion at the end of each case. Okay? So if you all are ready, we can start the first case. Let's start it. Okay? So we'll start for case 1. If you are all ready, let's start it. Well, the first case, this 10-year-old boy came complaining of inward deviation. The mother complained that she noticed a child having inward eye deviation. She started noticing actually like a week ago. She sought medical advice and told that the child has accommodative esotropia, and the patient were prescribed glasses, but she didn't do the glasses because she is not interested in this. The patient has no significant systemic. Mother was not happy for this, and she came for a second opinion if we have any other option other than having glasses. On examination, the vision was 6/9 and 6/12. The anterior segment was free, the pupils normal, and this is the ocular motility of the child. I'm showing this, the horizontal movement. You can see here a small angle esotropia, as you can see, and here is the horizontal movement. So here is the picture. This is a primary position, and right gaze and left gaze. After the patient received cycloplegic drops, this is the cycloplegic refraction of the patient, and the fundi were normal. So, audience, please be ready for the first poll. Share with us, if you face a case like this, what could be your first choice? Case of esotropia and hypermetropia. So what's next? So please, if you can, launch the first poll, and please put on your answer. Would you prescribe full cycloplegic refraction? Would you prescribe glasses, but you decrease the plus? Would you continue for orthoptic evaluation? I mean, measuring the angle of deviation in other positions? Or would you prescribe no glasses and just nothing more can be done? Or you have something else in your mind? So please vote, please. Everyone in the audience, please vote. Choose one of the 5 options. I will leave you for 5 seconds more. Okay. Let's see the results. Well, interestingly, 48% choose the first one. Okay. Let me share with my panelists what's your opinion about the findings now. Let me ask Dr. Mustafa. Dr. Mustafa, are you?
Yes.
What's your opinion about if there's anything significant in the history or in the video you would like to comment about, and what do you think about this results of the poll?
Well, of course, with the video you cannot see much of this eye movements problem. I mean the esotropia, but we have to proceed first for the total orthoptic evaluation or muscle evaluation.
Sure.
And then it's amazing that he's still amblyopic, slightly left eye. How about with subjective refraction? Does he improve the vision? And then we can proceed from there and see what's going on. But people saying giving glasses, it's very classic to say this.
48% suggest to give glasses with.
But you have to do all the examination first, and then you can start giving the glasses if you want.
Okay. So let's proceed for the more data from the patient. As you mentioned, Dr. Mustafa, we have cycloplegic refraction. We have to do the orthoptic evaluation of measuring the angle of deviation. Let's see the measurements. When we put the prism on the right, we have the esotropia of 35 prism diopters. However, when we put the prism on the left, we have esotropia of 25 prism diopters. And for near, we found an esotropia of 14 prism diopters. And here are the measurements inside gazes and other gaze. There's no significant pattern, but you can see on the right gaze is 14 prism diopters, and on the left gaze, it is 35 prism diopters. So my question to the audience, interestingly, we have a patient with this. So let me ask Dr. Akmal. Dr. Akmal, would you like to have a comment about this measurements?
Yes. It's interesting. First of all, we have an incompetence toward the left eye. Even it is not apparent with the motility. And the second thing, it's interesting that the angle at far is more than angle at near. And yes, this is not happen if there is the only cause is a 6th nerve paresis. And the 6th nerve paresis is not affected by all the fibers. I think the fibers, which is the slow tonic fibers, is only affected, not the fast saccadic fibers, because the motility is normal. And this is only happened with any the vascular insult or a long-standing 6th nerve paralysis. It's not a long-standing. I astonished that it is the recent.
Yeah, they noticed it like a week ago. Interesting.
It's very interesting. It's almost happens in old ages. And why is the angle at near is less than angle at far? Because at near we need only convergence.
Yes.
We don't need any action of the lateral rectus.
So you mean that it means that we have something in the divergence, right?
Yes, and I don't believe in divergence. We don't need any divergence. But on looking far, we need the relaxation of convergence and leaving the balance of the tone at far. The balance of the tone is weak, so the angle will be more at far because the slow tonic fibers is affected. But on motility, the saccadic fibers, the fast saccadic fibers, is good. So this is the explanation of the angle at far more than angle at near.
Interesting. You want me to show the video again for you? Okay. Okay, Dr. Oskan, do you have any comments about this measurements?
Well, I agree with Dr. Akmal's idea, and I think this is a clear-cut left sixth nerve palsy. So the motility restriction, it's not surprising not to see any motility restriction, because it is so common that if the palsy is not a total palsy, but it is a partial palsy, or as you call it, as paresis, then it's not uncommon not to see anything in eye movements. So that's the reason why we as ophthalmologists recognize more paretic problems compared to neurologists, because just looking to the ocular movements is the way of the examination of neurologists. But as ophthalmologists, what we do is we need to do prism cover test in all 9 positions of gaze in any case who had the sudden onset strabismus or any diplopia, either a child or an adult. So this is a basic rule, I suppose. So we need to continue as a sixth nerve palsy for this child.
So let me ask you a quick question. If you look at this motility, you can see now by the moving video that the left gaze, there is some limitation of abduction. So you based your diagnosis as sixth nerve based on this motility or on the measurements that we
on the prism cover test. It's the golden standard method is the prism cover test, because even in a lesser degree of sixth nerve palsy, you may see even less degree of measurements in prism cover tests with the sixth nerve paresis diagnosis.
Okay.
So in partial ones, my diagnosis is totally based upon the prism cover test measurements. And even in children, it's very easy to go ahead, because I do it by just covering the head of the patient while looking far.
Okay, okay. That's great. Okay. Let's move to the next question. And so with each of that, we have a suspicion, of almost we are confident that we have like left sixth nerve palsy. So the question is, and when you face a case like this, what cases you wish to order MRI in case of strabismus? Let me ask the audience: would you order case of MRI in which of the following cases? The first option, acute incomitant strabismus, when you face acute incomitant strabismus, or you face a case with acute concomitant strabismus. Let's say that measurements were comitant, but it's an acute onset. Would you do order MRI? Or number 3, every case of acute onset concomitant strabismus, or never in case of concomitant strabismus. You don't order MRI for cases of concomitant strabismus. So please share your opinion in the audience for this. Which of those cases you order MRI brain? Acute incomitant strabismus, acute comitant strabismus only if we have distance more than near. Every case of acute onset comitant strabismus, we never request MRI in case of comitant strabismus. So please, the audience share, please. Okay, thank you. So, okay, let me ask Dr. Hala. Dr.
Yes.
Hala, Professor Hala, what do you think about the results? 65% said that every case of acute incomitant strabismus, they will order MRI. So what do you think about the results? Interesting. And then 26% said that every case of acute onset comitant strabismus, they will order MRI. Do you agree on this?
Actually, I prefer to be more cautious than being sorry. And that is why if I have an onset of strabismus that is an acute onset, and I don't find the refraction overly hypermetropic to explain that this is an accommodative ET. I would rather be safe than sorry. And even if it's a concomitant deviation, because even some kids are are too young to get really good measurements on. And as you said, sometimes the limitation of abduction can pass unnoticed in motility exam. So I would rather get an MRI on any acute case of acute onset even if it's a concomitant deviation. And definitely, if you have a distant near disparity, I would definitely get an MRI on that person.
Okay. So you do and request MRI for every case of acute onset strabismus, even for concomitant strabismus, right?
If that case, I cannot explain it as an accommodative esotropia. If it's not a high hypermetropic patient, like your patient from the start, it's not someone that I would prescribe glasses and think that the deviation would be corrected by that kind of refraction. Okay. So I would have a high index of suspicion for someone like that.
Okay. Let me ask Dr. Amr. And
regarding the same,
you order MRI for every case of acute strabismus, even if it is concomitant?
Well, I wish the answer was that simple, because you have to play two factors come into play here. First, you have to take into consideration what exactly is acute. It's not always easy to know if the onset is acute or not, because you depend on history in this. And if you're talking about a young child who's 1 year old or 2 years old, you may not get such a clear history from the parents. Second, age comes into play here. This child is 10 years old. So if I have a new onset strabismus with diplopia in a child who's 10 or a 9 or an 8 or even a 7 years old, I would order an MRI, whether it's comitant, whether it's incomitant, any form of MRI that cannot be explained by local changes in the eye would definitely order an MRI. But the answer is different if you're talking about a younger child. If you have a 1 year old or a 2 years old, it's not unusual to see strabismus that starts at that age, and we would not explain. I'm talking about strabismus not explained by hypermetropic refractive error, and the history is rather acute, and still I would not have a high index of suspicion. And in that age, the younger age, let's say younger than 3 or younger than 2, I have to see some incomitance in order to order an MRI. There's no clear-cut point. I can't say like a specific age beyond which we order MRI. But I would say that the older the child is, I'll be more and more inclined to order an MRI, even if it's comitant. And neurological diseases can present as acute comitant esotropia.
Interesting. So Mustafa, I would like to, and what do you do? When do you order an MRI for such side, or if you have any comment about?
Well, I totally agree with what my colleague said, but I only want to mention here that when we're talking about, like Dr. Amr said, about the age group. I mean, now we are talking about really early age group, and because older age group, we think about vascular insufficiency, I mean the old age, but this young age group, we are not dealing, except if we think sometimes about idiopathic ones, which happen to be maybe 20-25% of the cases. That's what the literature said. So we normally, as I didn't really thought about, but when I read about it more, I found it's really at this early age, when you have acute, non-traumatic sixth nerve, you have to think about something going on in the brain. I mean, something like tumor or anything happening at this age, because it's really very frequent. And as Dr. Hala said, it's better to be worried and safe than to be to leave it like this. But there is something I want to mention here that you said. Diplopia in this age, when things happen very fast, you'll find the kid coming and really blurred, and he can tell you there is something wrong. But this situation in this case, you said you didn't say this, so it means and be progressive, because he didn't really notice it as much as a sudden attack.
Yeah,
That's what I wanted
it was not the main
to mention.
complaint of the patient. Actually, when I asked him several times about double vision, he said sometimes on the left gaze I can see things blurred, but it was not the obvious diplopia that we usually see in acute onset, in acute sixth-nerve palsy.
Yeah, that's what I was saying. I mean, normally when cases are coming with acute onset, even in a child after the age of 8 years, 9 years, they really mention it directly. And we know normally people, even old age, whenever they don't really mention the diplopia, so it's something going on for a while, and they did sort of adapting themselves to it. And this is not the case here.
Okay. Turakman, you have something to comment? Turakman?
Yes. It's amazing that if it is acute onset, the child should come with head posture, abnormal head posture. So it is a very old history. The most common cause in this age is a non-localizing, or it is a benign increased intracranial tension. This is the first thing I suspect, and I should see the fundus first. And if I examine the fundus and I see papilledema, so I determine if I ask for MRI for tumor or for a benign increased intracranial tension for medical treatment or something like that. But for the features I am dealing with, it's not acute because there is no head posture. Any young child, 10 years old, even he complain of diplopia, or he has head posture, normal head posture to the right. And from the people, she hasn't any abnormal head posture.
Yeah, there was no head posture.
But we should ask for
scanning. Okay.
Yeah, Dr. Özkan, you want to add something?
Yes, thank you. For this child, as I mentioned, I would go on accepting this child as a sixth-nerve palsy. But regarding the poll question, if we consider about asking an MRI and so on, if it is an concomitant strabismus, as I believe in this child, at any age, I would ask for an MRI. But if it would be an acute concomitant esotropia, so this is another issue, as it is mentioned. So we mustn't give the message that all acquired esotropias require MRI. So we know that it's a very common situation. Acquired esotropia at 2-3 years of age, it is very common, and we don't ask for MRI. But there's a gray zone that we don't have a very clear-cut age group. But I think it wouldn't be so wrong if we say that the age group enough to talk about diplopia are the ones who actually require MRI. But on the other hand, the only small thing that I wish to add is acute concomitant esotropia was a rare problem in previous years, but recently it became a common problem. And so this is mainly as on screen basis a problem. So those children who spend lots of time with mobiles and the computers, then they start to come with the diplopia and acute concomitant esotropia. We started to see it much more common compared to previous years. And I just wanted to mention this, but despite this recent problem, in an age group who has complain about diplopia, I always ask for an MRI in a concomitant acquired esotropia.
Thank you. Okay, so
Dr. Hala, you want to add something?
I just wanted to add something very briefly. Definitely looking at the disc is important, but also trying to see if there's any nystagmus that the patient has. If the patient has gaze-evoked nystagmus or a downbeating, interesting to think of is the Arnold-Chiari malformation, because that also results in an angle that is at distance bigger than near, an esotropia that is more at distance than near, and sometimes that's something that is missed.
Yeah, that's good.
There's a question just from the audience. Is there any small left hypertropia in the right gaze? Dr. Ayman, was there any small vertical deviation?
It was not, yeah.
Okay.
Okay, so let me show you the MRI. This was requested MRI. This patient requested MRI, and the MRI showed a significant supracellular lesion. It was quite big. It was like 3.5 centimeter by 5.5. So this patient was referred to an oncologist, and the biopsy has showed an astrocytoma, and then the patient is receiving chemotherapy now. So to conclude this thing, I'd like to ask every panelist to have a very short one-sentence take-home message for the audiences in such case. Dr. Akmal, please.
Yes. Any acute incontinent, especially incontinent strabismus, we should see the fundus and do neuroimaging. And I agree with Dr. Amr that there is a high percentage of acute concomitant strabismus with the neurological problems. So some advanced countries, they do this neuroimaging even for all acute strabismus.
Okay.
Okay, thank you.
Dr. Mustafa, should be one sentence as a take-home message to the audience?
Well, I totally agree with Dr. Akmal. I just wanted to say that acute strabismus, as we said for neuroimaging, I want to mention also that even in old age, that we think it's vascular, they found out by literature that there is a big number that comes from even some tumor or something like this, even in diabetic patient or hypertension. So you have to keep in mind that we have to worry about this acute problems.
Okay, Dr. Hala, you have a last...
I'm fine. No, I'm good.
Dr. Oskan, can you give us the last message from this patient?
Well, there are a few messages, but I think I've already said it. The first is prism cover test measurement in 9 positions of gaze. And second, the acute comitant esotropia in an old child. And third is incomitant strabismus that certainly require an MRI scan. And also acute comitant strabismus in an old child certainly requires an MRI imaging, I suppose.
Okay. Thank you very much. Dr. Dina, can you check if you have any questions from the audience? We can take one question from the audience.
All the questions answered. Just it has been asked several times. The child doesn't complain of any double vision, so I think it's just at the side gaze.
Yes, it's a good wait for this patient.
Yes. Okay.
Okay. Thank you very much. That was a very interesting discussion. I learned a lot from you, and I hope the audience enjoyed this discussion. Thank you very much for this. And let's move to the second case. So I'm asking Dr. Oskan. Dr. Oskan, please, can you share you can start sharing your presentation?
Yeah, I tried to start, but it doesn't let me to share. Okay.
So the next presentation will be from the Professor Oskan. She will show a case presentation. Okay, yes, we are seeing it. Please proceed.
Okay, thank you very much. And so as I suddenly jumped into the discussion in the previous case, I couldn't say a proper hello to everyone. So it's my distinct pleasure and great honor to participate in this webinar organized by EAPOS, and I would like to thank the president, Dr. Professor Mohammed El Sada, and it has been a great pleasure for me to be together with friends from Egypt as well. So I'm going to start with my case. It's an 18-year-old female, and her main complaint was abnormal squint on left gaze. And this was there since her birth, and history was unremarkable. And she also complained about some ptosis, but her major complaint was the squint on left gaze. She didn't have any previous treatment. On ophthalmological examination, she had 20/20 vision in both eyes, and she was orthophoric in primary position at near and distance. And she had a pretty well stereo acuity with TNO 120 seconds of arc. So when we look at the eye movements, we saw that in left gaze, there's a very slight limitation of abduction with a significant upshoot on abduction in the left eye, and a significant limitation of depression on abduction in the left eye. So when we look at the prism cover test measurements in 9 positions of gaze, you can see that on left gaze, there's a large hypertropia as large as 40 prism diopters, and on left down gaze, it is 50 prism diopters. So this is how she looked. If you look at the here, you can see the globe retraction on adduction, abduction, and on elevation. And when you look at the left gaze, you can see the significant hypertropia in the left eye. So I'm going to show you the video of this patient. You can see better the globe retraction. Sometimes there's a little bit upshoot on adduction, and you can see the upshoot, significant upshoot on abduction. And if you look at here, yeah, you can see the significant limitation of depression of the left eye. And in the midline, the depression is quite good. And on the right gaze, there is not so much problem. So for this patient, so what is your diagnosis? This is the poll question. The first choice is left inferior rectus palsy, left double depressor palsy, left vertical Duane syndrome with atypical features, and abnormal extraocular muscles, accessory muscle or atavistic muscle related strabismus. So while waiting for the answers, well, I was also thinking about what could be for this patient. I think we haven't get the answers yet, but so I think what I was mostly thinking in my mind was that this patient had left vertical Duane syndrome, or it may be in combination with abnormal extraocular muscles. So if we look, yeah, so the majority considers that this was a vertical Duane, there was a globe retraction. This globe retraction suggests the Duane syndrome. And some of them also considers the presence of abnormal muscles. So in consideration of those, we asked for a kinematic MRI for this patient. So let's see what we saw. And this is the axial plane. And when we look, let's have a look to the horizontal gaze positions. And as you can see here, there is nothing wrong. Both the medial and lateral rectus muscles in the left eye, there's no abnormal paradoxical contraction, and there's nothing extraordinary. So now let's have a look to the coronal scans. So this is while looking on right, and this is while looking left, and you see the motion here. If you look at the superior rectus muscle, this is on abduction. You can see that the superior rectus muscle demonstrates a paradoxical contraction on abduction. And this patient also had a normal brainstem MRI examination. So, considering those findings, the next poll question, what is your treatment plan? First choice, left superior rectus recession. Second, recession of both horizontal rectus muscles of the left eye. By splitting of left medial rectus muscle, or leaving the patient alone, no surgery at all. So left superior rectus recession, recession of both horizontal rectus muscles, while splitting of left medial, and no surgery. So I think we're going to have the answers. It didn't appear yet, so I'm going to tell about what was my plan. My plan was to consider a left superior rectus recession. Well, actually, we can see that there is a significant percentage of the participants who considers no surgery. So my plan was to operate superior rectus muscle. And so, but as we know, it is very important the results of the forced action test. So to my surprise, in forced action test, it was negative both on elevation and depression. However, it was positive on abduction. So because of this finding, I decided to discover the reason for this forced action test result. So I decided to explore the medial rectus muscle. As you can see here, nearly 10 millimeters back from the insertion, there was a translucent tissue And after the dissection of this translucent tissue, the tissue was, this was the largest appearance that we could get. So I have excised this tissue as much as I can. And I also performed a superior rectus muscle recession. I first have done the recession for 5 millimeters, and on adjustment, I've increased to nearly 8 millimeters during adjustment. So this is the tissue band, as you can see here. So I've sent this material for histopathological examination, and there was no muscle tissue inside. And when I discussed the surgical findings with my friend who's a radiologist, Professor Erkin Arıbal, I must acknowledge him. And when he retrospectively evaluated the MRI images, he could see this tissue band here and also this one. But these are on its own, he could not make any comment about the presence of an accessory tissue band or accessory muscle. So this is how she looked after surgery. This is 1 month postoperative. As you can see here, she's doing pretty well, and the hypertrophy on abduction decreased significantly, and the limitation of depression also decreased significantly, as you can see in the video and also in the photo here. And yes, and now I think you can see better. It is less than that. And if you take care about the right gaze, there's a little bit downshoot in the left eye. So this is postoperative 5 months. She had a little left hypotropia on right gaze and a small left hypertropia on left gaze, and this is the result. So to summarize this case, so vertical Duane syndrome is a rare form of Duane syndrome. It's characterized with globe retraction on vertical gaze with limitation of vertical ductions, but this is not always present. And there may be a vertical deviation in primary position or at side gazes, and there may be a paradoxical contraction of vertical rectus muscles or in lateral rectus muscle, or the paradoxical contraction may be in accessory extraocular muscles. And if I say a couple of words about the accessory tissue bands, and in a large series from Deemer's group, they reported that 2.4% of strabismic patients have abnormal tissue bands, and 42% of those are from the group of CCDD. However, in an earlier report based on surgical findings, Goben reported that in Duane syndrome, the incidence of seeing abnormal tissue bands during operation was 34.3%. So the take-home messages are: in bizarre motility problems like this, consider primary position deviation, ductions, and globe retraction. Second, consider MRI, and if possible, consider doing a kinematic MRI in those strange problems. Forced duction test is crucial at all steps of surgery. It is actually crucial in all strabismus cases, but especially in those ones, it is more and more important. And consider the presence of accessory muscles or bands, and vertical or accessory muscles may paradoxically contract, and surgical plan in such cases needs to be individualized. And I'd like to thank for your attention. Just before the discussion, I would like to remind that the joint meeting of ESA and ISA, which was planned to be done in September, it is postponed to April 2021 because of COVID-19 pandemic, and the standalone ISA meeting will be held in 2022 as planned before. Thank you.
Thank you, Dr. Scams. Please, I'm asking you to keep the presentation. Thank you. Thank you, Dr. Özkan.
Sorry.
If you don't mind, share again the presentation. I think we'd be interested to see the preoperative video of the movement.
Okay.
And I'm really it's a very interesting case, and I'm really very interested in hearing the ideas of our panelists. Okay, so I would like to share.
You want to, I think, see the video.
Yes.
Is that right?
Yes, the video of preoperative, yes. Okay, may I ask Professor Akmal, when the video will show to us, what's your comment about the assessment of such patient? And I think we had to choose the.
Yes, I think that
I couldn't see the
to explain that Dr. Sihan had told us about every detail, because for me, I will consider the kinetic MRI. But what is interesting to me,
this is the preoperative.
yes.
Okay, will you please run the video? Yes, the video now is running. Let me ask you about what's your impression in, clinically when examining this patient, Professor Akmal?
Me?
Yes.
Yes. I'm seeing that she has both in abduction and in abduction elevation, not only in abduction, but on cover and cover tests, there is no hypertropia on right gaze. This is interesting. But I see in motility, there is upshoot.
Yes.
Can you repeat the video, Dr. Oskan, please?
Yes.
Yeah, Dr. Akmal has mentioned that in her right gaze.
Yeah.
Is this an upshoot, or maybe it's because of the ptosis that make this impression?
I mean, if you wish, I can go back a few slides. In prism cover test measurements and on motility examination test, I've mentioned that this there is a small +1 upshoot, but it is not always. It sometimes goes there and sometimes it didn't. And during this video, she made this little upshoot.
Okay.
So, okay.
Sometimes, okay. Any other comment from Dr. Akmal about the clinical presentation?
Dr. Sihan had told us every detail.
There are many questions from the audience, though. Dr. Hala, first, you have a comment, yes.
Yes, I have a case that's similar to this one, and I just wanted to ask you about the superior rectus muscle in this case. Because this, in cases like this, this is a disinnervation, and this is I find that the muscle was not a normal superior rectus. It was more fibrotic and thinner. So I don't know if you had the same experience with the superior rectus, or was it a normal superior rectus for you?
Well, actually, during surgery, I was also expecting to see more abnormality in the superior rectus muscle, especially after I saw the paradoxical contraction of superior rectus muscle on abduction, which was very clear by the kinematic MRI examination. But it wasn't like that. The superior rectus muscle did not appear abnormal during surgery, and forced suction test was also negative. But I've done a huge recession to the superior rectus muscle, but I think that this patient had two components. First of all, from the beginning, when I saw this patient, there were many possibilities about the paradoxical contraction. It could be even there may be a problem in inferior rectus muscle. There could be a problem, I mean, in that kind of abduction, upshoot on abduction can also be related to the medial rectus muscle. It can also be related to an accessory muscle. It may be related to the superior rectus muscle. And it may also be related, one major consideration before the MRI for me was whether there would be any compartmental paradoxical contraction in this case, even at the superior rectus or in lateral rectus or in medial rectus muscle. So there were lots of possibilities. So that was the major problem while planning the kinematic MRI, because when you're doing a kinematic MRI, the radiologist asks you, what do you want to see? Then I told the radiologist that I want to see all of that. So that was a major problem for this case. But as you mentioned, I don't want to talk a lot. the superior rectus muscle was not as abnormal as I saw, but the medial rectus muscle, the tissue band below the medial rectus muscle, was the most peculiar finding in this patient, because I have seen other strange tissue bands and accessory muscles before, but I haven't seen a similar one like this. So, and the appearance, if you look at the retrospective MRI, it looks as a superior oblique muscle, this tissue, but it is not possible to identify where did it originated and so on, because the tissue was actually so thin, even in the posterior parts.
Okay, fine. Let me shift to Mustafa. To Mustafa, what's your thought about this paradoxical movement and also this vertical deviation? What's your opinion?
Well, sure, it's complicated for all of us, but I want to ask Dr. Sian, do you really in your work or Dr. Demer work, does it show more, is it more paradoxical innervation or more fibrotic muscles in this type of vertical doings? I mean, our both components together. What do you think?
So in order to call a condition, any condition as Duane syndrome, we have to have a paradoxical innervation.
Yes.
It doesn't matter which muscle is it, but if there must be a paradoxical contraction. So this is actually the main differential diagnostic thing from the other types of CCDD or isolated fibrosis and so on. So, and the paradoxically contracting muscles usually have secondary fibrosis, as we see in typical forms in Duane's syndrome. So, but of course, we now know that the origin of a fibrotic element is actually innervational. But the level of fibrosis, the secondary fibrosis, is so variable depending on the patient that it's not possible to say that it is the, I mean, in some cases, the clinical outcome and the clinical appearance, the motility pattern is more related to the paradoxical problem. And in some of them, we know that it is more related to the fibrotic element. So, but it is always combined. So, but in this combination, the level of these paradoxical contraction and the fibrotic element is so variable. It's not possible to say just this is the major.
No, no. I mean, in your study or Dr. Demer's study, we couldn't really find out some clarification on this, no, from the MRI, no?
Oh, yes, okay. But from MRI, it's not possible to comment on the level of the fibrosis, yes. But I mean, we can make a comment on MRI, the size, the appearance, the function, but we cannot make a comment how the level of restriction that this muscle causes. But if you ask as a like a pathological, do you mean to ask the fibrotic element within the tissue?
No. I mean like Dr. Demer was in some cases trying to clarify, saying that sometimes the innervation of the inferior part of the medial rectus works more, so that's why we have this upshoot in these cases or not. I mean, he's trying to find out some relevant innervation or some MRI study.
Okay, I think you asked about the compartmental problems. In this case, this was one of the possible etiological factors, but we couldn't find any compartments. But after his definition about compartmental problems, when we retrospectively looked to our old images, we have seen that compartments are really very, actually very clearly seen in lots of MRI sections, but this is an area that we need to make lots of investigation.
Yes. So mostly we have to work also on per-operative, work. Whatever you feel when you are doing the surgery, the reduction test and all the stuff had to interfere also with your type of surgery that you have to do. That you have to change sometimes if you feel like what you said, some positive reduction, and you have to go and find what's interfering with the medial rectus action.
Yes.
Okay.
Yes.
So there are a couple of questions repeated from the audience. First question is, what about her left ptosis? Is it related? Do you consider treating this ptosis?
I do not do oculoplastics, so I refer this patient to an oculoplastic expert after finishing her work with the strabismus surgery, but she hasn't yet have done the ptosis surgery. But this was also her complaint. But I didn't do anything, and I don't do ptosis surgery.
Yes, your explanation about her ptosis. Is it related to her condition?
Well, of course, in origin, there must be some relation, but if I go through the postoperative appearance, and this is 5 months after, the ptosis is nearly the same in primary position. But of course, the eyelid follows the eyeball, and in the preoperative phase, there was a lid retraction on downgaze, as the left eye could not depress on abduction, which was also one of the big complaints of her. So I actually don't know yet whether she had the surgery or whether she would actually want for surgery.
Okay, and another repeated question, the concern of affecting the primary position after such a large superior rectus recession in an orthophoric patient in the primary gaze. Did you have, okay.
Yeah, I also have this concern, and that's the reason why I use adjustable sutures. Why I use adjustable sutures always in all adulthood strabismus. But this is a case that, those who do not use adjustables very commonly, this is a patient group that certainly requires adjustable suture surgery, because at the end, this recession was 8 millimeters. So before adjustment, I recessed the muscle for 5 millimeters. Before the operation, I didn't know how much to recess, because it was totally up to the result of the forced action test. But as the forced action test was not positive on depression, I recessed just for 5 millimeters. But when as I saw that there was still hypertrophy on left gaze, I increased and I checked the elevation and depression. So that's why I could do an 8 millimeters. If I wouldn't do an adjustable surgery, I wouldn't be able to recess her superior rectus muscle as large as 8 millimeters. So that this is the importance. Thank you for this question. This is a good point that to point out about the importance of adjustable suture surgery, especially in those cases.
Before concluding the case, I would like to hear the opinion of Dr. Amr about the paradoxical movements. What do you routinely do to detect the paradoxical movement? Like you order MRI for this, you do EMG. Do you have any clue of detecting it, or you just rely on the clinical picture?
Well, I don't think, I don't routinely order EMG. I mean, the two methods, the investigative methods would be the EMG and the MRI. I don't routinely use them, and I don't think we really need them, because if we rely on the motility patterns and the force reduction test, we can really take the decision in this case. It's without doing the MRI, we can see with the over elevation in abduction in this eye, we can tell the superior rectus is overacting or paradoxically contracting, and I would recess it if I would operate on this case. However, apart from this, I would like to add a comment that although this case had a happy ending, recessing the superior rectus and removing the fibrous band on the medial rectus could actually end with a motility pattern that was not predicted. Yeah, I understand that doing a superior rectus on adjustable can always give us a reversible path to go if we have an overcorrection. But removing the medial rectus band will not give us that. If I see this patient, I would discourage her from surgery. If we do operate, yes, I agree with Dr. Oskan, that's what we would do. But the difficulty here is if this case does not end well after the first surgery, if we get a new incompetence, if we get a primary position hypotropia, if we get an incomitant hypotropia, I think it would be very difficult to repair in a second stage surgery. So I might agree with some of the audience comments that we may not be very enthusiastic about operating such a patient, although we can see where the paradoxical contraction is.
That's a nice point. Dr. Dina, do you have more questions from the audience before concluding the case?
There's a couple of questions about why not considering this a case of congenital fibrosis of extraocular muscle. Why did we say it's a Duane case in the first place?
Yeah, I think I actually answered this question during the previous discussion, because this patient has a significant globe retraction, which demonstrates us the paradoxical contraction. So the presence of paradoxical contraction indicates that this is a Duane syndrome. And considering the concern of Dr. Amr, I would like to mention that in this patient, the tissue band below the medial rectus muscle caused a very significant restriction. So because of this, I wasn't concerned about cutting this out because it was something abnormal. It was causing a significant restriction and the rest of the muscle was pretty good. And I also have seen the medial rectus muscle. For such a patient, I wouldn't go on surgery without seeing the MRI results, because sometimes the accessory muscles, muscles or tissue bands may be in such a location that you may even not consider to do any surgery. But in this case, it wasn't like that. So I must say that considering the, I just, may I have a couple of minutes to
yes, sure.
comment on EMG and MRI? And regarding the EMG, I was actually doing lots of EMG in previous years. As I do botulinum toxin injections as a routine, I'm used to using these EMG things. But the problem with the EMG is that EMG only shows us the electrical signal where the tip of our needle is. So it doesn't show us the significance of this abnormal contractility. The significance is shown on MRI. So, and on the other hand, EMG is always, if you try to do an EMG on 4 rectus muscles, there are few patients who can be cooperative and so on. Considering the MRI, the kinematic MRI is a difficult examination. It lasts long, but I must say that this images, previously we were using 7 positions of gaze, which was lasting long. But nowadays, my colleague, my radiologist colleague, Professor Arabal, is now using just 3 positions of gaze. So 3 positions of gaze give you the necessary information, and I just wanted to mention that. Thank you.
Actually, this case is very rich, and I think yeah, discussion can last even more hours than this. But we have to shift for have to conclude to shift to the next case. Thank you, Dr. Oskan, for this nice presentation. Thanks for all the panelists. Let's go for the next case. And for those who feel this case has a heavy discussion, the next case is an anterior segment pediatric case. So my colleague Dr. Dina will start. Can take over from now, Dr. Dina?
Yes.
Okay, so I'm going to start my case, and this is a diversion from strabismus surgery for a little while. I've been getting comments that my voice is not very clear, so I'm sorry for the quality of the internet.
Now it's quite clear.
It's good? Okay,
Yes,
so I'm
very
hoping
good.
also that, that the video clip that I'm showing will run a little better than when we tried it. So this is an 8-year-old girl who is completely asymptomatic, but her parents, when on presentation, told us that when she was 6 years old, the only thing that they noticed was the white opacity within the pupil. And based on that, they sought medical advice, and they were told that she has a cataract, and that the cataract was caused by uveitis, that she had a chronic uveitis. This led to the diagnosis of juvenile idiopathic arthritis. And when you really insist on the history, they would tell you that she did have a left knee pain shortly before or around the time when they noticed the white opacity. So this is a case of juvenile idiopathic arthritis, which is less common. The uveitis happened probably before the knee inflammation or before the joint inflammation. So she received topical and systemic anti-inflammatory medication at her first doctor. And she underwent left cataract and intraocular lens surgery in the left eye 3 months after starting the medication. So this is what she looked like when we first saw her. This is the right eye. She had a visual acuity of, counting fingers, 50 centimeters, a shallow anterior chamber. There was no anterior chamber activity in that eye, but you could see that there were posterior synechia, a poorly dilatable pupil, a total cataract, and their intraocular pressure was 14 millimeters mercury. This is the left eye. This is the eye that had undergone surgery, and you can see quite a lot going on there. She had a visual acuity of hand movement with good projection of light. There was a lot of inflammation with anterior chamber cells and flare, a shallow anterior chamber and iris bombay because the optic of the IOL was captured within the pupil. And it was also cocooned in a dense membrane, the edges of the optic. The intraocular pressure in that eye was 10 millimeters mercury. She was on medications already. She was taking topical steroids, drops daily in the right eye, 4 in the left. She was also on oral steroids and methotrexate subcutaneous injections weekly. Still, she had an active inflammation in that eye, and she was extremely photophobic, and her photophobia was really incapacitating. So I referred her to our uveitis clinic, where adalimumab was added, the biologic agent. Her topical steroids were increased to 6 times a day. Her oral steroids were also upped. The activity did tone down, but was not completely suppressed. And the uveitis specialist advised me that the intraocular lens had to be explanted. So this is where we are going to our first poll question. In cataract surgery for a juvenile idiopathic arthritis, I would implant an IOL. I would never implant an IOL. I would remove the cataract now and perform secondary IOL implantation 6 months to a year later.
That's an interesting question.
Mm-hmm. So, Dina, would you like to take it from here and ask the panelists a few questions?
Yes. So, Dr. Mustafa, what's your opinion in IOL implantation in juvenile idiopathic arthritis?
Well, I think that Dr. Hala mentioned in her talk that we are talking about 10-year-old. So if we see that the child very early, I think I would rather remove and leave it without IOL at the start. But if it's old child and well treated and balanced, I mean for at least 6 months, so I may consider putting an IOL at that moment if everything is all right.
And So just how would you avoid ending up in this situation? Do you have any guarantees that it won't have the same fate with optic capture and chronic inflammation not responding to treatment?
Well, of course, there is no guarantee, but I mean, you try to find that this child is well balanced with the treatment. I mean, no inflammation, and your rheumatologist saying that for the last 6 months he's under control, and we are getting less the treatment. And at that moment, you can maybe put him under steroid before the surgery and do as me and Dr. Hella is doing, putting the oil in the bag and trying to put some steroids inside and keep him well monitored. I think you may have this. And of course, cycloplegic drops like atropine is better. I mean, before and after. I mean, it's always a risky situation, but we try to balance if we feel that we are well managed. But if you feel that you are not sure about this child, or is very, I mean, it's early in life, I mean, especially at the first 2 years, I mean, no problem, but at least at this situation, you don't put an IOL. You just leave him alone and see in 6 months or 1 year after.
So Dr. Hella, what do you think?
Okay, so I agree with the poll. I'm very happy that the poll came out this way, that I would remove the cataract now and perform secondary IOL implantation 6 months later. And so first of all, we've done a lot of these cases in Cairo Children's Hospital, and we are able now to choose the right procedure for the right patient. So for this girl, for example, she developed the uveitis, an aggressive uveitis, which was so aggressive that it led to a complicated cataract. And you have to note here that the complicated cataract was not related to any treatment, because sometimes the cataract is the result of the steroids. But that happened before she was diagnosed with juvenile idiopathic arthritis. So this was a cataract that was the result of a chronic inflammatory reaction that she had. She's a girl, and she developed the inflammation very early on in life, before she was 6 probably. And when you have all these red flags, that makes you very cautious with an IOL implantation. She's an oligoarticular patient as well. But if that patient had been older, had she been a polyarticular patient that had only a mild inflammatory uveitis and more joint inflammation, then I might consider under supervision with the pediatric rheumatology and uveitis specialist to implant an IOL for her. But in most cases, I think it is safer to do the cataract surgery, test the waters with that, and test the eye's reaction, the reaction of the eye to the surgery, defer the IOL until 6 months to a year later, especially since this patient was also bilateral. So there was no real need to implant an IOL. She's not a unilateral case. There's also, how can I avoid ending up with this? First of all, you have to really justify why you're doing the cataract surgery for them. So if my cutoff vision for doing for performing cataract surgery in a child is 0.4 or 0.5 vision, here it would be much lower. This patient would have to have really poor vision for me to do a cataract. And a lot of them, even if the cataract looks really bad, they still have reasonable vision. I wouldn't rush into cataract surgery for GIA patients. The patient has to be completely in remission for at least 3 months. And you have to work very closely with the uveitis specialist, with steroids topically, immune suppression, and adalimumab, biologic agents. And as I said again, choose the right candidate for the right procedure. If we can go on. So in this case, prepare the patient for the surgery, which I really did not want to do because it looked like it was going to be a difficult procedure. I upped the meds after consulting the uveitis specialist. We increased the topical steroids, And I gave her a subtenon triamcinolone injection a week before. And we scheduled the surgery to be right after her Humira injection. Now, the difficulties in this procedure, in this cataract surgery, is the fact that you don't want to instigate a lot of inflammation. So you don't want to be too traumatic with your surgery. You don't know where the haptics are, because the lower haptic is actually incarcerated in iris tissue. It's not behind the iris, it's in iris tissue. So I was really worried about instigating a hemorrhage, a severe hemorrhage from the ciliary body by the surgery. So I just wanted to get the IOL out of the eye. And if anybody is looking for a glamorous surgery, this is not it. It's just a surgery to get the IOL as safely as possible. I'm sorry that the movie is not running as fast or as well as I want. So these are the two side ports in incisions, and viscoelastic is then injected in the eye. And I'm using the viscoelastic blunt cannula to try to disentangle the IOL from the inflammatory cocoon around it. And then I'm trying to, I'm using the Sinskey hook to dial the IOL, and I'm trying to get it out through the path it went in, because I don't want to be pulling on any ciliary processes or any part of the ciliary body. Now this is the corneal clear corneal incision, and 23 gauge vitreous forceps are used to support the IOL and hold it in place, while the Vannis scissors cut the IOL in. I'm not cutting it completely in half. I'm just creating a cut involving half the diameter of the optic. I've exteriorized one of the haptics, and then I'm using McPherson forceps to cartwheel the IOL out of the eye slowly. It's really done very slowly. And now I'm left with the inflammatory membrane and the pupillary membrane, which is very dense. I'm trying to create an edge here in the membrane. And then I'm using scissors to cut the membrane. In opening membranes, I prefer using an insulin needle, 20 gauge needle, on viscoelastic to better create cleavage and open planes up. The beauty about having the viscoelastic is that if any bleeding starts, you can inject viscoelastic right away to tampen out the blood. This is the membrane and the scissors being used to remove it. So after I completely remove the membrane, I want to do an iridectomy here because I'm worried about another inflammatory reaction and glaucoma. This is an anterior vitrectomy with a 23G probe, and I'm very happy that I'm getting a really nice red reflex. I'm also going to use the 23G probe to ensure that I have a full thickness iridectomy. All my incisions are closed, and I'm injecting triamcinolone 4 milligrams in the vitreous cavity, and also I'm injecting subtenon, triamcinolone, as well as atropine. So this is the surgery. This is 2 days post-op. I only did this case a week ago. You can see that there is a mild inflammatory reaction, which is what we expect. But you can see also the slit beam image of the eye, which is fine. So in primary IOL implantation in cases with juvenile idiopathic arthritis, it's imperative that you get the IOL in the bag. If you're not going to get it in the bag, you might as well not put the IOL, because you don't want the optic to be chapping against the back of the iris and creating chronic inflammation. The difficulties with the implantation is you have a poorly dilatable pupil. What you can do is mechanically dilate the pupil, as you see in the picture. It's important to use capsular staining to be able to enhance your visualization of the capsule. But the important thing here, or the difficulty, the real difficulty I find, is that the texture of the anterior capsule is very different from what we know. The capsule is very thin. It shreds very easily because of the inflammatory reaction that it had sustained. So it's not easy to get a good capsulorhexis on these patients. If you do have an intact rhexis and you put the IOL in the bag, you should go through the pars pliccata to do a central posterior capsulectomy, anterior vitrectomy, and again inject the triamcinolone. Now, this is the second poll. Dina, would you like to?
Yes, so management options in this case are removal of the pupillary membrane and repositioning of the IOL, explantation of the IOL, exchange of the IOL, or surgery should not be attempted.
So actually, in this case, I was hoping that surgery would not be attempted. And this is why I was hoping that by upping her medications, we would be able to avoid going to surgery.
Seems that this was inevitable, but such a wonderful surgery, very challenging indeed. Okay.
So yes, great. So yes, in cases like that where you have the optic or the IOL actually chafing against the iris all the time, and you have a chronic inflammation that you really can't suppress completely, the only thing to do would be to explant the IOL.
Dr. Mustafa,
yes.
would you have done the same?
Yes, of course, if I can, yes. Very nice. Yes, I do the same exactly. You know, especially when she said we cannot monitor this case. I mean, sometimes if you feel that you can monitor such a case with treatment and you can avoid interfering, of course you can do this. But I mean, in this type of situation that you had, there is no option. You have to explant the IOL, yes.
Okay. And Dr. Hala, what about the other eye now? What's the time interval to consider removing the cataract of the IOL, the cataract, and then what about the IOL implantation of the other eye as well?
Thank you for the question. It's a great question. Actually, I'm going to keep an eye on the eye that's been recently operated, and just make sure that there is no inflammatory reaction. Once the inflammatory reaction has subsided, and I would give it at least 3 months before I attempt to do surgery on the other eye. And when I do the other eye, I will just do a simple pars pliccata lensectomy, anterior vitrectomy with triamcinolone. I don't want to go through the anterior chamber again. I'd rather not manipulate the iris a lot. So that would be my way to go.
And do you think there are specific type of IOLs that induce less reaction than others? Dr. Mustafa, what's your preferred type of IOL if you consider a secondary implantation in those cases?
Well, of course, yani, as Dr. Hala mentioned, you have to be in the bag. I mean, this is the most important part of the situation. I mean, a long time ago, you are using some type of heparin coated or something like this. But I mean, with the new types of IOL, I think I like the 3-piece. I mean, I like the 3-piece and put it in the bag. Why the 3-piece? It's easy to manipulate. If anything happens, it's easy to explant. I mean, rather than 1 piece that normally sort of amalgamate with the capsule and the tissues. I think, yes, I will do it in the bag. I'll do it carefully and do all the precautions I can and wait, as Dr. Hala said, in even such a case, even if it's quiet, and wait for 6 months or 1 year out to implant.
I actually think that the lens is, what you said about the lens is perfectly true. Had this lens been a single piece IOL, I'm pretty sure I would not have been able to get the haptics out. I would probably have ended up by amputating the haptics and leaving them in place. So a 3-piece IOL is the best choice here, a hydrophobic acrylic 3-piece IOL. Mm-hmm. And as you see, in the midst of all this inflammation, it was easy to dial it out through the track that the haptics already created. So Yes.
And there's a question from the audience. You prefer to remove this membrane using the microgauge instruments rather than using the vitrectomy cutter?
Yes, I do.
Any reason for that?
Because sometimes, even though when we're using the 23G forceps, you can inadvertently injure the iris. And I would rather use something that I'm trying to create a cleavage plane, whether you do that with scissors or as I prefer with the side of the insulin needle, the sharp side of the insulin needle. And that dissects planes for you. But the vitreous cutter sometimes would not dissect a plane, and it would be cutting the membrane, cutting the adhesions, but it may cut part of the iris with it.
Okay.
So that's why.
Okay.
And
in
I'm
such cases, sorry.
Yes.
Yes, go on, Dr. Hel.
I wanted to know if Dr. Mohammed Asseda would like to comment on this case if he's with us, if he's still with us.
I don't think, yes,
No,
Dr. Mohammed
okay.
is here. No, he's here.
Okay, Dr. Mohammed.
This is a very interesting case, actually, and well, every case has to be monitored according to the situation. Whether to implant or not to implant depends on the severity of the condition. The severity of the condition is related to the control of the uveitis. If you can control the uveitis by the moderate medications, then this is what I call a simple condition. If you cannot control the uveitis except by extreme medication, then this is a difficult condition. If the difficult condition, I leave the patient aphakic. I would rather leave the patient to be corrected by glasses, aphakic, and not to implant an intraocular lens. But if the condition is controllable easily or moderately by medication, by an average dose of steroids and immunosuppressives, then I would go for intraocular lens implantation. Intraocular lens implantation after 6 months is going to be very difficult because the capsule is going to be collapsed and the synechia is going to obstruct the sulcus even. So you will end up by no sulcus and no capsular bag to implant inside. So it's either you implant primarily or you don't implant at all. But after 6 months of chronic uveitis, don't expect to find a suitable bed for implantation. It will be difficult. It will need manipulations. And the more you manipulate in those cases, the more you get a post-operative inflammation. I liked very much the delicate touches of Dr. Hala in dealing with the case. And the message or the take-home message from her video is that you have to be quick when you are dealing with a case like this. And at the same time, you have to use the most delicate instruments and the most delicate manipulation in order to prevent the release of the mediators and the inflammatory factors that can result in a post-operative inflammation. But in total, I do agree with her procedure, and I think it was an excellent one.
Thank you. Dina, can I just go back to the question about using the vitreous cutter to remove the pupillary membrane? What I meant to say is, first of all, you need, again, to create a plane of cleavage between the membrane and the iris. But once you've done that, then definitely, certainly, you can remove the central part of the membrane using a vitreous cutter. It's just that the edges is what I worry about, and again, creating just a good plane of cleavage between the membrane and the surface of the iris. And I agree with Dr. Mohammed that after leaving the patient aphakic, if there is a severe inflammatory reaction that has closed up the sulcus, then there is no reason to go back and try to implant. But if the patient had a reasonable post-op outcome with little inflammation and an open sulcus, then I would go back and implant an IOL. And in that case, I would attempt to put the optic incarcerated in the capsular opening that I have to keep it as far away from the iris, the surface of the iris, as possible. Thank you.
Yeah, your sound, Trudina, your mic.
So doing an optic capture then, Dr. Hala?
Yes, I would try to do that. I would attempt to do that.
Have you ever managed to put the IOL in the back in case of secondary implantation after 6 months? Not just in a uveitis case, or in general, in a pediatric case.
Okay, now that's interesting, because I used to try to do that, but in order to do that, you have to leave in your primary procedure a little bit of cortex between the anterior and posterior capsule so that they don't fix together, so that they're not amalgamated together. Mm-hmm. And when I did that in an attempt to leave a donut that I could later open, I got a lot of pupillary membranes or secondary membranes because I left the cortex. So if I do a really good cleanup, then I can't open the leaflets, and I don't implant in the back, and I do a sulcus implant. Sometimes if I get cases where I do have quite a bit of a donut, and when I'm able to open that donut well and remove the cortex, then I can implant the IOL in the back.
Dr. Ayman, I'm certain there are lots of questions from the audience, right?
I'm trying to collect the question from a lot of questions from the audience, but some of them have been already answered during this interesting discussion. I have a couple of questions from Dr. Jamal Blake. I would like to welcome him for this question. First, he showed his opinion about that if you have a reaction pre-operatively, he recommends putting topical drops, topical steroid drops, and never implant IOL if you have reaction pre-operatively, and then putting if you are going to put IOL to be only in the back. This is also his first comment. The second comment is about the posterior. This question for him: the posterior capsulotomy. Would you do posterior capsulotomy in such case of uveitis? To which age? Do we do it regularly as we do in regular pediatric cataract surgeries, or you recommend to extend the age or decrease?
So actually, in a uveitis patient, I would do the posterior capsulotomy up to the age of 10. Whereas in other in pediatric cases, I would stop doing it between 6 and 8, depending on if the patient is cooperative enough to sit for YAG, for example.
Okay. One more question has been asked about, would you consider giving prophylactic anti-glaucoma? Because are we expecting to having post-operative rising intraocular pressure? Will you do it prophylactically, or you don't do this? In such case,
it's very difficult to expect anything with this patient. You cannot expect, because the pressure can go up, but also because of the chronic inflammation, the pressure may be very low. Like in this case, she had an intraocular pressure of 10, and that worries me. To have an intraocular pressure of 10 millimeters mercury when you have an iris bombay and a pupillary block tends to tell me that her ciliary body is not producing a lot of aqueous. So you don't know which way it will go. So I wouldn't give it prophylactically. I would give it if it rises.
Okay. So I think we have to conclude for this nice, interesting case. Thank you, Dr. Hala, and thank you for the rich discussion. And we go forward to the last case.
Dr. Dina, please start your...
Yes. Now the screen should be shared, right?
Yes, it is.
Okay.
Very interesting case.
Okay. So, my case is a 6-year-old boy with a history of dog bite at the age of 2 and a left upper lid repaired wound. Here's his cycloplegic refraction showing an isometropic cylinder and he's amblyope in this left eye, having a best corrected vision of 0.2. And the parents came complaining of outward deviation of the left eye, started 1 year after the accident. So here are the preoperative pictures of the boy, showing the left exotropia with a small hypotropia. And he had a significant V pattern with a large upgaze exotropia and a bilateral inferior oblique overaction, more evident in the right eye. He had a significant limitation in elevation, both in midline and in abduction, with what seemed like a bilateral superior oblique underaction on both sides. The boy had a positive head tilt test. On the right head tilt, he had the same angle of a small left hypotropia as the primary position, but on the left head tilt, he showed a left hypertropia of 16 prism diopters. And he had an objective fundus extortion in both eyes, extorsion more in the right eye. Here are his measurements. The primary position, he had a 35 prism diopter exotropia for near, 40 prism diopters for distance, increasing to 70 prism diopters in up gaze. In the right gaze, he had a left hypertropia of 20 prism diopters, and in the left gaze, he had a right hypertropia of 35 prism diopters, along with the vertical deviations, the right hypertropia of 8 prism diopters, increasing to 16 on left head tilt. The CT of the child showed here, as seen in the axial and the coronal images, a calcified trochlea, but the comment came also, it could be a suspected foreign body. So here's my first question. What do you think might be the cause of limited elevation in this case? Superior rectus injury, inferior rectus tightness, superior adhesions from the previous dog bite, or the suspected foreign body? Okay. So I can see that most chose that the superior adhesions are the cause. So again, to our case and our panelists. Dr. Amr, what do you think of this case?
You know, usually with trauma, you don't think much. Everything is possible. So I think we'd go for surgery with an open mind, and you do a force reduction test, and you decide intraoperative. There is no manual for the glaucoma, for the trauma. There's no way to go. There's no pre-planning for this. It all depends what you're going to find inside the surgery. But yes, it sounds like it's possible that some fibrosis on the superior side of the globe where the injury was, it was causing this limitation. Yeah.
Okay. And Dr. Hala, what do you think?
Yeah, I agree with Dr. Amr. That, well, you have to plan the surgery though. And I'll leave you to show the plan, because it's something that we did together. So
okay,
I won't comment.
Okay, Dr. Özkan, I want to ask you about this limited elevation along with the extortion he has on both sides and the positive head tilt test.
Well, this patient, I think, obviously had components of both a paralytic problem and an adherence problem. But I would definitely ask for an MRI preoperatively for this patient. But
okay,
it seems to me that this patient, despite he had the foreign body and adherence problems as well, despite the positive Bischofsky head tilt test, he had some paresis in the left superior rectus muscle and the secondary overaction of the inferior rectus muscle, led us to see as the right superior oblique is underacting, and because of the limitation of elevation, especially more on abduction, the inferior oblique overaction is also secondary to this limitation. So, but at the end,
what would be your surgical plan? What would you start with?
Well, considering the surgical plan, my choice would be, first of all, as I said, I must see the MRI first.
Mm-hmm.
But, and if we don't have the MRI, what I would suggest for this patient is, first of all, he is 6 years old. Before surgery, I would give chance for amblyopia therapy, because any increase in visual acuity would lead the exotropia to decrease significantly in that case. And
for 8 months, he was very resistant to amblyopia therapy. We tried it for 8 months with intensive part-time occlusion, and he did not respond. 0.2 was the best vision he could achieve.
Okay, so in such a condition, what we need to do is to treat the squint that the patient have, not the original problem itself. So I would suggest for this patient that if I'm going to, first of all, I need to correct the exo deviation, I need to correct the hypo, and I also need to correct the V pattern. So this is not a binocular patient. So what I would do in this patient is to make a recess resect in the left eye, as well as supraplace both of them, one tendon width, and do an inferior oblique disinsertion in both eyes.
Inferior oblique
disinsertion. Bilateral.
Okay.
And in the left eye, recess resect plus supraplacement of
both
placement of one tendon width of the both of the horizontal muscles.
Okay.
So this would correct the hypotropia, and this would also eliminate the V pattern, and so I think it would also help for the limitation of abduction. But of course, the results of first action and so on, it's all. But the adherence problems, as long as you operate the areas of adherence, you create new problems.
Okay. So here is what has been done. There's just a short video just for the first part of the surgery. We started by marking the 6 and 12 o'clock positions and by the force duction test, which was positive for tightness for both infraducting and supraducting the globe, and extremely positive for the superior oblique or the upper nasal quadrant, and free for the inferior oblique. The plan was to initially explore both the superior and the rectus and the superior oblique, and exploring the superior oblique tendon after identifying it and hooking it from the temporal side to avoid the area of adhesions at the upper nasal part, which were really extensive. There was also the suspicion that the superior rectus might be injured, but it was intact. And here I'm just showing how to hook the superior oblique tendon from underneath the superior rectus by just replacing the belly of the superior rectus a bit nasal. You can identify the beginning of the fanning of the fibers of the superior oblique and hooking it, making sure you identified the tendon and that did not miss any posterior fibers of the tendon like shown here. So we want to secure our tendon by passing 6 ovicral sutures or any suture material underneath the tendon, and just simply by getting it from the nasal side of the superior rectus. Now we have the tendon identified, secured. The video stopped?
Yes.
Okay, I'm sorry. just here. And also the superior oblique tendon was intact, wasn't injured, but there were extensive adhesions extending posteriorly here. And as much as we could, we severed those adhesions. And the more those adhesions were released, the more the globe got free. So the plan was yet now to repeat our force duction test and see what's going on. And fortunate enough, the globe was relatively free with free introduction, subproduction, just a very bloody field though. So what happened now, we examined the fundus prior to the surgery, and the extorsion, although it's more difficult or it's not, we can judge it under GA as when the patient is awake, but the extortion was significantly exaggerated after releasing those adhesions. So at this point, would you consider the following to correct the objective fundus extortion we are already seeing? Left superior oblique tucking, left inferior oblique weakening. You do both, or you just ignore this extortion and just do the recess resect to correct the exotropia. I was fortunate enough in this surgery to be assisted by Dr. Hala herself.
It's a pleasure.
Thank you. So left inferior oblique weakening.
Gina, this child did not have any binocularity to start with, right?
Yeah, he's not fusing. So what we've done is graded anteriorization of the inferior oblique 1 millimeter from the inferior rectus, along with the lateral rectus recession and the medial rectus resection without any transposition. And here are the post-operative pictures of the child. He was perfectly aligned in the primary position with still the significant limitation not improving, whether in the midline or in the abduction, but there's a considerable correction of his V pattern. And as you can see, the overaction of the inferior rectus was corrected here, along with the inferior oblique overaction and superior oblique underaction in this eye or the other as well. And here are his post-operative measurements compared to the pre-operative measurements written here in red. He was just having this small ET in down gaze with the +1 inferior oblique overaction in his right eye, in left gaze, and the XT in the up gaze of 25 prism diopters as compared to 70 prism diopters prior to the surgery. So, Dr. Özkan, have you got an explanation of the correction of those gazes, but still the limitation is still the same?
So you performed an inferior oblique anterior position of the left eye, is that right?
Yes, okay. Without anything on the right eye.
Well, I think considering the limitation of elevation, this is not a satisfactory result. For the rest of it, it's okay. And I still believe that it is because that the left superior rectus muscle is not functioning well. So when there is a paresis in the superior rectus muscle, then as it is an intortor at the on the other hand, so the amount of extortion related to the superior oblique palsy is more exaggerated. So if you would do the transposition surgery that I recommended, you would have a better elevation. And if you would do this bilateral inferior oblique weakening and on up gaze, you would have a more symmetrical result. And this is what I suggest. I think in an eye, I would actually personally would never do an anterior position surgery in a child who already had a limitation of elevation, despite it is more prominent on the abduction. So, the problem is to have a symmetry in both eyes. So in that case, this asymmetry on up gaze increased, despite the V pattern is not there, the exodeviation is not there, okay, but now he had more asymmetry considering the vertical deviation on up gaze.
Okay.
This is what I suggest.
So do you think if we had an upward transposition of the medial and lateral recti, would this have ended him in a hypertropia in the primary position?
I don't think so, because on the other hand, I would do this insertion of the, you ask whether it would cause an hyper? I mean, because he already had a hypo preoperatively, so this is what we want to treat. So we want to elevate this eye. And on the other hand, we have this V pattern phenomenon. So, we would decrease the left eye over elevation by disinserting that. And it would be enough to correct the hypotropia, a full tandem with transposition parallel to the spiral of Theo.
Okay. Dr. Akmal.
Yes.
How do you think that he ended up having a vertical orthotropia while we weakened the inferior oblique, which is an elevator at the end? I have no explanation, but do you have one?
Yes, the dog bite was in the left eye.
Yes.
Yeah. So it's like some sort of canine tooth.
This is what I wanted to suggest, but can we say it's a canine tooth where there is a limitation predominantly in adduction in cases described as a canine tooth syndrome? He doesn't have a limitation of elevation in adduction, so not a classic one though.
But if I will touch this patient, I will do for both bilateral inferior oblique disinsertion.
Okay, like Dr. Oskan
because
suggested.
the V pattern is not corrected. It's 25 prism up and 8 TT down. Why don't you touch the right inferior oblique?
Why did we do the right inferior oblique in the first place? Why didn't we do it?
We didn't.
Yes, we did. Actually, our plan was to start with the left eye because the parents were very disencouraged to operate on the right one because of this is the seeing eye. Okay. And Amr, do you have any comment?
Yeah, I think I'm looking now at the picture you're showing is a picture of an anti-elevation syndrome, and one of the audience suggested that you just created an anti-elevation syndrome, and that's what I see now. I'm not really sure if you really needed to do anything in the oblique, or was it really useful in this situation? Once you release the restriction, you may have ended up with a different picture. And next thing is the other thing I want to talk about is the intraoperative assessment of the excital and making decisions based on that sometimes can be very misleading. Of course, you don't have a fusing patient, so you may not want to correct the excital torsion much. You use that, I assume you use that to know if the inferior oblique is going to be overacting, so you can use this to correct the hypertropia. I did a simple experiment once of trying to kind of a blind experiment to assess the extorsion before and after regular inferior oblique myectomies, and it was very difficult to see it, even though I just did an inferior oblique myectomy. So I think, yeah, I'm not sure if the inferior oblique did much in this case. I think releasing the adhesions did most of the job.
Okay, Dr. Hala?
Okay, I just wanted to just comment here that once we released the adhesions, so the adhesions were like creating a tether in that eye, and the tether made this eye hypotropic. But once we released the adhesions, what we thought was that we would be ending up with the superior oblique palsy, and that we were actually going to make the superior oblique palsy now become more apparent. And this is what led us to, and that became evident to us by the more extortion that appeared in the fundus and in the rotation of our marks.
But why anteriorization? Why doing an anteriorization? Why not a myectomy or recession?
Actually, what the anteriorization that we did is not a true anteriorization. So what we did was we put the inferior rectus, the anterior pole, 1 millimeter behind the temporal border of the inferior rectus, and the other pole even behind that. So it wasn't creating a J deformity in any way. It's we call that an anteriorization, but actually it's not. It doesn't. Normally that wouldn't create an anti-elevation in that patient.
No, my question is why not a recession or myectomy? Why did you think of this modified anteriorization, if you would like to call it?
Because it worked. Yeah, I use that when I have superior oblique palsy in one eye. I never anteriorize so that I'm level with the inferior rectus or anterior to it, but I go behind it, and I always put my posterior pole of the muscle even behind the anterior pole, and that works really well. It is a form of a recession. It's just a little bit more than a recession.
Okay, so it's like this is your routine procedure in cases of simple superior oblique palsy?
Yes, that's what I do. Well, it depends. Actually, no, I wouldn't say that. It depends on how much hypertrophy I would have in the primary position with the superior oblique palsy. But I can go up to 1 millimeter behind the inferior rectus to get an effect of an improvement maybe of 15 to 16 prism diopters of hypertrophy. And okay, I don't get a J deformity with that.
Mm-hmm. Dr. Özkan, I want to say a comment before you say it's. You had an article about the leash and the reverse leash phenomena, but just in post-operative cases. So what we thought of is that this case, what caused the hypotropia is the reverse leash, and by severing those adhesions, this this leash is no longer there. And the elevation or the anti-elevation is present here. It's just not induced because this is exactly the picture the child had preoperatively. Actually, his elevation even improved a bit, but not as much as we hoped for. So
actually, what I would like to say is that I think that a lot of the adhesions recurred where after they were severed. And I remember that after the surgery, he had a bit of a hematoma in the eye. And that made me pessimistic about the fact that the adhesions would not return in that area.
Mm-hmm. Yeah, Dr. Özkan, you had something to say?
Considering the leash, this leash and reverse leash phenomenon was described many years ago by Jan Polsky. It is so in this child, it also plays a role. But the thing is, once these adhesions develops, and especially in the posterior part, if there is any disturbance of the orbital fat or so on, whatever you release during the operation, afterwards it will the adhesions recur. So in this child, I think those adhesions mask some of the problems, and when you release the adhesions during surgery, you see, because of those adhesions, the paresthesis in the superior rectus muscle was not so apparent. But when you release those adhesions, then with the less intorsion effect of superior rectus muscle, then you saw an increase in extorsion. This is my explanation why when you release those adhesions, you saw an increase in extorsion, because it was actually the fact. If you but of course, this is something so variable that you cannot know how those adhesions. Sometimes some of those adhesions may mask some of the major problems. Sometimes they may become some kind of advantage for masking some of the problems. I think this was the case in this patient.
Yes.
And I would like to comment on anterior positioning of inferior oblique muscle. I also do a similar type of anterior position frequently, but I must say that it is obviously, although its effect is not as much as suturing the posterior fibers at the same level of the anterior fibers. Its effect is different than making a disinsertion or a myectomy. It is in a much more anterior location. So in a patient who already had a limitation of elevation, I think it certainly added more for the limitation of elevation here. And I would like to ask you, what do you consider as further operation in this child? And if you would like, I can say my comment.
I wanted to ask you this question. Actually, that was my next question.
Well, after that stage, it seems that you would have to convince the parents to operate the right eye and to do an inferior oblique disinsertion in the right eye. But now you need to make a superior rectus faden in the right eye as well to have some asymmetry, because this asymmetry is quite significant. This is what I suggest.
Okay. And do you think the presence of bilateral superior oblique palsy in this child is an independent of the trauma he had? Because the trauma doesn't explain the classic bilateral superior oblique palsy signs he showed.
Yeah, this is something that I commented before. As this child, so when you have a superior rectus palsy, you have a limitation of elevation. So the eye remains here. So this secondary overaction of the inferior oblique muscle makes the other eye go up. And when you have a limitation here, you have a secondary overaction in the inferior rectus muscle. And this secondary overaction will let you see that as if this right superior oblique muscle is underacting, but this is actually secondary to this, what is happening in the rectus muscle in the left eye. So my suggestion is the right eye thing is totally secondary to the primary local problem in the left eye.
Okay. Dr. Mustafa, you wanted to add a comment, I can see.
I just, what I wanted to say here, when we saw the case from the start, I don't feel that all what in the eyes is only spread of comitance. I feel that he had already something before, such an XT, a V pattern XT of 70 prism. I doubt it's just the spread of comitance or due to other trauma. I think it had already something, and it added on it this type of trauma. And when you deal with this situation, I would have dealt, like Dr. Özkan said, I would have just said, yes, I put lateral and medial for the left eye and then put them up to elevate the eye. And then you have to deal with the V pattern XT as any V pattern XT. I mean, the lateral rectus would be recessed and bilateral inferior oblique and put them up. I mean, I don't feel that I have to deal part by part. I always like to have all the problem try to deal with at the same time, because if not, if I do part and then wait for the other, I get another situations in a few months. So I'm going to deal with another problem, not the first problem, to add some surgery. So as we have here, we have to redo something. And I still was going to do what Dr. Özkan said from the start, just go again and put the medial and lateral rectus for the left eye up and deal with the inferior oblique recession for the right eye. I think that would be quite satisfactory.
Okay.
But if we do now the elevation of the medial and the lateral recti, the patient is orthotropic in the primary position.
So what? No, I don't think it's going to end up with hypertropia left eye. No.
Why not?
Because it's only a deficient of elevation. It's like double elevator. I mean, you have deficient elevation. So at that time, you always get this slightly up and doesn't get disparity of both sides.
Okay.
I mean, I don't see it.
So now, any questions, Dr. Ayman, from the audience that haven't been? I see the discussion is here. We took a long time, and we're running out of time.
Yes,
we're actually beyond time already.
Questions from the audience, but let me ask you one question is asking about again the force reduction test. You mentioned in the surgery that was some limitation in elevation. Is this
elevation?
Right?
Yes, and that's
the question is why don't you offer inferior rectus restriction? To maybe because this kind of restriction and can improve this hypo and it may improve the elevation.
It was indeed an option, but we thought it's a reverse leash rather than the inferior rectus itself is tight. So like releasing those adhesions might do a better job than leaving them and going for the inferior rectus recession.
Yeah.
Anything to add, Dr.
Yeah,
Hala?
one question asking about the foreign body. Explore searching for a foreign body. And another question related that the MRI show, before actually the MRI, there was suspicion of having a foreign body. So you have any fear of doing the MRI, expecting this foreign body could be have anything metallic?
Actually, the report stated that it might be a foreign body, but it's actually the calcified trochlea. I don't know if I can get back, but it's in the, they call it the bone window scans of the CT showed that this part is faint. It doesn't have this intensity of the foreign body, so it was more likely to be a calcified trochlea, and this was the case. It wasn't, and we could actually palpate this trochlea nodule. It was apparent in this boy.
The last question about to avoid the recurrence of fibrosis. Some audience suggested mitomycin or amniotic membrane. Would you consider this in such patients?
It is an option, correct, but we did not do it.
May I comment?
Yes.
Just as you talk about mitomycin, in any strabismus surgery, considering about mitomycin is something, it's a concerning agent because it reduces the wound healing reaction. So when we suture the muscles, we need wound healing. So if you stop this, you may end up with slipping muscles, and because your muscle will not adhere as you expect.
Okay.
Yeah, I just wanted very quickly to comment that I do agree with Dr. Oskan that everything that is going on in the right eye is not a primary deviation, but it's secondary to what is going on in the left eye. But that also includes even the extorsion that you saw in the fundus. It's when it's like a secondary type of deviation, because when the patient is trying to fix with the paralyzed eye, the other eye will not the eye with the problem. When he tries to fix with that, the other eye will show the extorsion, and that also sometimes gives people the impression that there is a bilateral fourth nerve palsy when it really isn't. So depending on extortion alone, it's again a secondary deviation, not a primary.
Okay. So yes, Dr. Ahmed.
Yes, I want to support the Dr. Mustafa Sherbini. I think the patient has something before the trauma, because the V pattern is very high, and the preoperative 70 prism diopter up. I think it is the V pattern exotropia. On top, she got a trauma. I think so. I support Dr. Mustafa for that. Okay. This is the last comment.
Okay. Okay. So I think we have to conclude now, and it's been 2 hours. We're sorry for our audience and for keeping you late. And Dr. Ayman, can you just announce our next webinar?
Yes, we announced that this is just the first webinar, and we are planning to have a weekly webinar at the same time for the coming 2 weeks. And I wish we receive the same kind of audience or even more. And finally, I would like to thank Professor Oskan for being with us in our first webinar, and please be safe. And I'd like to thank all the panelists. And of course, I'd like to thank even Pharma for supporting this. And lastly, I'd like to thank all the audience for staying with us for more than 2 hours now.
Thank you, Dr. Hala. Thank you, Dr. Ahmed. Thank you, Dr. Oskan, Dr. Mustafa. Thank you, Dr. Am. And thank you, Andrew. Thank you, Eva.
See you
Pharma.
next week. And
yeah.
In our
See
next
you. And Ramadan Kareem.
Yeah.
Thank you.
Bye.
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 Have a great night. Bye.
Bye.
Thank you.